All right, and we're back. So, picking up where we left off, I want to look a little bit on the left side of the screen over here, over at the microcytic anemias. We just talked a little bit about the macrocytic non-megaloblastic over here. But iron deficiency, anemia of chronic disease, the thalassemias, we'll look a little bit about these. So, kind of patients you want to look for. Just to pick up hints for tests and for boards. Iron deficiency, you think about GI bleeds, some with cancer, like a colon cancer. Um, uh, Women of reproductive age, you want to think about menstrual bleeding, malnutrition. Pregnancy, you actually get a kind of an iron deficiency anemia as well as dilutional anemia, as you guys learned. Um, Alpha thalassemia, family history. We'll talk more about this, but Asian populations have the cis deletion. African populations tend to have the trans deletions. So the Asian populations can get a little bit more severe anemia. Beta thalassemia, also look for that family history, more of a Mediterranean population. Lead poisoning, the classic is kids who ate paint in old houses. So you're looking for some sort of exposure, as long as the other symptoms of lead poisoning, so abdominal pain, maybe some neuropathy, stuff like that. Sideroblastic anemia is hereditary. It's X-linked, so look for it in boys. It can also be caused by other things, not necessarily genetic. Alcohol, copper, B6 deficiency, medications that cause B6 deficiency, like isoniazid, and then look for ring sideroblasts is going to be your thing. But to differentiate between all these, you really need some iron studies. So that's what we're going to talk about a little bit about iron. So ferritin is the storage form. However, you can see elevated ferritin and other things because it's an acute phase reactant made in the liver. So if there's some sort of infection going on, that's going to be way thrown off because it's going to be really elevated. Serum iron, so that's just the iron in the blood. It's bound to transferrin. TIBC is kind of a measure of the actual transferrin, not necessarily bound to iron though, remember. And iron saturation is the percent of these iron binding sites that are occupied, so kind of the serum iron divided by the TIBC. A little bit about iron metabolism. I'm not going to get too into depth with this, but iron is mainly absorbed in the duodenum. It's absorbed into the enterocytes by a couple of these transporters here, then moved to the basolateral membrane, where it is moved by ferroportin. So ferroportin is blocked by hepcidin. So if you want to decrease kind of the iron coming across, you make more hepcidin. Hepcidin is stimulated actually by IL-6 release, so infection. Kind of prevent those iron utilizing bacteria. You'll make more hepcidin. It's also made in response to increase in transferrin. So basically, if you have a lot of iron bound to transferrin, you have high iron levels, there's a negative feedback loop that increases your hepcidin levels that will then go and block iron absorption to prevent you from getting too much iron. So that's a little bit of this diagram here. You can see kind of a busy slide, but as iron is absorbed here, bound to ferritin, it comes you can absorb it through this ferroportin. Increased ferroportin in the blood bound to transferrin feedbacks to the liver and will increase your hepcidin production to make this negative feedback loop. So iron deficiency anemia can be normocytic earlier, but then it usually progresses to more of a microcytic. Most of the time when people actually get severely anemic, you know it's going to be pretty microcytic. It's associated with pica, so people who eat ice have this weird craving for ice, spoon-shaped nails, increased red cell distribution. You can get Plummer-Vinson syndrome, which is glossitis, which remember can also be seen in B12 and folate, but you can get it in iron deficiency as well. Iron deficiency anemia and esophageal webs. So again, like I said, some populations to look at. So the labs, this is going to be a big thing you're going to be able to interpret on the boards and on the wards. Iron deficiency, decreased stored iron, decreased serum iron. TIBC goes up because the body is trying to deliver more iron to the tissues, so the binding capacity increases. But because you have such a low iron, remember transferrin saturation is iron over TIBC, that saturation is very low, and you have increased RDW as well. Chronic disease, think of it as the body thinks it's infected, so it's storing all the iron away. So the serum iron is can be lower, but all the iron is in storage form, so its ferritin is high and the TIBC is low because your body's trying to hide iron from itself, if that makes sense. So you can have like a decreased saturation, but you have a high ferritin. So depending, like iron deficiency, ferritin is the first thing that goes, your storage iron. So if you are kind of suspecting iron deficiency, but the ferritin is high, that's going to tip you off that it's anemia of chronic disease. Sideroblastic and thalassemia, these look pretty similar, but remember on your smear, you're going to be looking for sideroblasts versus a thalassemia. You're going to look for target cells, and you're also going to diagnose this by electrophoresis. And also a good family history to help as well. So for thalassemia, you have very high red blood cell turnover. So you have a really increased ferritin, increased iron, because your body's trying to absorb more iron. It's trying to pump out these red cells because it's really, EPO is kind of stimulating that iron absorption. So you have very, very high iron levels. And you can have a increased RDW in that as well. Also something you see in thalassemias. So thalassemias, it's decreased globin chain production. You can have alpha or beta. An imbalance of these causes kind of the precipitation of these globin chains into these ineffective forms, and not too alpha and too beta, but groups of beta tetramers, and these can damage the red blood cell membrane. And because you can't make these chains properly, you get anemia. You get kind of this extramedullary hematopoiesis if it's severe. Your body's really just trying to pump out blood, and increased iron absorption as well. And that's why I said, you get that really high ferritin serum iron levels in thalassemias here. So you can give a wide range of presentations. Really, you're going to have to look at the electrophoresis to differentiate. So alpha thal, chromosome 16. You have 2 copies of the gene, so you can have a wide variety of presentations. You can be a carrier. You can have a deleted copy on each of the genes, so that's the trans inheritance. It's more common in Africa, or on the same gene. So, if you think about it, you're not going to have the transferring these genes. You're not going to have as severe anemia in the further population, and trans inheritance as you will cyst, because you could get high drops with this, right? You could get both mutated copies from each parent in Asia, but you wouldn't really be able to get that in Africa. So here's just a little bit about, I'm not going to read this whole thing to you, but obviously as you get more mutated chains, you get more severe anemia. High drops is incompatible with life. You don't make any alpha chains, you can't live. HBH is a very severe anemia. You have really severe splenomegaly. You get this hemoglobin H, which is these beta chain tetramers, because you're trying to make all these red blood cells, but you really only have one functional alpha chain. So all these extra beta chains form tetramers. They damage the red blood cell membrane. You get this hemolytic anemia. You get massive splenomegaly. Very severe disease. In high drops, you get hemoglobin Bart's, which is basically the same thing as the beta chain tetramers, except for it's gamma chains because it's in a fetal, the fetal hemoglobin and gamma chains, and they die in utero. Beta thalassemia, so chromosome 11. You can have, again, a wide range of either absent or reduced hemoglobin. You want to look at the hemoglobin electrophoresis to diagnose this. Beta thal major, the most severe. So if you have both mutated copies, can have, again, a very severe anemia, hemolysis by the alpha tetramers, kind of similar mechanism, hepatosplenomegaly, and you need chronic transfusions or a stem cell transplant. So electrophoresis, briefly, you can see the types of hemoglobin: normal hemoglobin, alpha, beta. A2 is delta change, which remember made kind of low level throughout adulthood, and hemoglobin F, which is the gamma chains. So normal, you have 97, 1, and 2, just low levels of A2 is adult pattern here. In alpha thal, remember you're losing the alpha chain is in each of these forms, right? Alpha, alpha, alpha. So the overall pattern is going to be the same in alpha thalassemia. In beta thalassemia, you're going to have kind of these relative increases in the other types of hemoglobin, right? The ones with the delta and the gamma chains. Oops, I'm sorry. So that's kind of how you recognize that. Beta thal major, you don't have any beta chains, so you have all hemoglobin F. Again, this is the one that prevents extremely severe anemia early in life, because all you have is these gamma chains, which disappear quickly after birth. Sickle cell trait. You'll see these mutated beta chains in basically half of the chains, and then sickle cell disease, you'll see hemoglobin S in all of them. You can also have variations of sickle cell, like hemoglobin C, and that'll show, again, like a kind of a similar pattern with that. But you'll have S and then C. So let's move on to the macrocytic anemias. So over on the right side of that, your original chart, talk about B12, that binds to R binder. The parietal cells in the stomach are kind of the key to all this. They produce intrinsic factor, which binds to B12 and absorbed in the ileum. So if in any step along the way from intrinsic factor to absorption, ileum, you can get a B12 deficiency. So malnutrition, usually people who just don't eat enough, period. Loss of pernicious anemia is going to be the most common cause, autoimmune destruction. If you have a gastrectomy that removes all of your parietal cells, that'll do it. You have Crohn's disease or anything else that's affecting your ileum, or fish tapeworms is the other, because they actually absorb all the B12. They steal it from you. So pernicious anemia, antibodies to parietal cells usually, but they can be against the intrinsic factor or the receptor as well. So because you don't have intrinsic factor, you're not able to absorb it. You also have increased risk of gastric cancer, another association to be aware of. So you get the kind of clinical syndrome, you get these hypersegmented neutrophils. You can see, normally you should have like less than 5 lobes. This one has like 8. Glossitis, and then neurological symptoms, peripheral neuropathy, affects the cortical spinal tracts and your DCML pathway, and you can get dementia as well. But this is a reversible dementia, also key for step 1. Folate. So poor diet, alcoholism is going to be a big one. Folate blockers. So you can see this chart over here, where those comes in. So dihydrofolate reductase inhibitors, so TMP, trimethoprim, and methotrexate are going to be those. And the folate deficiency, 5-FU, another chemotherapy drug. So the big lab findings to distinguish these, obviously you get a low folate, but you can measure serum methylmalonic acid, can also be helpful. So that's going to be very high in B12 deficiency, but it's going to be low or normal in a folate deficiency. But folate deficiency is very similar, B12 overall, but you don't have kind of the neuro symptoms associated with B12. So we're now going to move on to the normocytic anemias. We spent a lot of time on the hemolytic anemias, but for the non-hemolytic anemias, you get chronic disease and iron deficiency, which also could be microcytic, and we talked about those. You can get aplastic anemia from chemo, radiation, parvovirus, other causes, bone disorders, which we're going to go over, and also CKD, which we talked about, decreased EPO production, meaning the body just stops making as many red blood cells. Next, we're going to move on more to the